First of all, thank you all for that are joining today. This is going to be our first webinar of a series, and we are calling this the Montana Antimicrobial Stewardship Coalition, or MASC. It does look like some people are still slowly joining, but for those of you that did join, we do appreciate you taking the time out of your busy day to join us. So I will turn it over to Vince Colucci now.
Alrighty, hello out there, everyone. Let's start my slideshow here. I'll leave my ugly mug up for a second there, so if people want to put a name to a face, that's great. As Erica had mentioned, this is our initial showing of our webinar that we'd like to kick off. We've been trying to get this up and going for a couple of years, and I think that we finally, between COVID and CDC funding and so on and so forth, so we're kind of launching this. So glad that everyone's joining us. I think it's to be a very good participatory, engaging, and educational type of a format that we're looking at here. Again, as Erica mentioned, we kind of acronymed ourselves, at least the base group here, the Antimicrobial Stewardship Coalition, or MASC, if that works for everybody. It's an easy acronym to remember there. We would ask that, let me start the slideshow here. Put your name, if you would please, position and facility that you're affiliated with into the chat box. If you're not from Montana, great, that's fine. Just include the state that you're from. And then if you have multiple people that are joining, include everybody that's there. Again, I'm going to emphasize this again and again. The concept here is this group participation and engagement. And I think that's kind of where we're going to get most of the benefit from this. We don't want this to be kind of a preaching or a top-down push out to anyone. Rather, we'll lead the discussions, we'll throw things out, but we want participation, and we'll get into that here just in a little bit more. Again, turn your webcam on so we can see your lovely faces out there. How are we going to construct this? What's the format of it? Well, so if you can see, we've got some timing components there that we've put in here. So really the webinar hour, we're going to kind of focus in a 5 to 10 minute introduction. And that's kind of what I'm going through now. And this one will be perhaps a little bit longer just to kind of introduce how we're going to do this. And then we set forth on the next slide, as you'll see, kind of an academic curriculum. What we'd like to do there is just before the case presentation is put in a component or a piece or an element of an academic topic or subject that has been in the literature, it's in the guidelines, something along a principle of antimicrobial stewardship or infectious disease principles that we'd like to just reiterate, underscore, bring to your attention, so on and so forth. So that'll be about a 10 or 15 minute presentation, and that will be from different healthcare practitioners and infectious disease practitioners and clinicians throughout. Okay. Again, we're going to start off with once a month concept. Ideally, we'd like this to increase maximally up to once a week, but I think for the first year or so, we're going to try once a month and see if we can capture a good audience and good education and good participation. After that academic piece, then we'll go into the case presentation, and the case presentation will be about a 15-20 minute kind of vignette, hitting and underscoring some principles throughout the case, some questions that are that we'd like to kind of throw out to the group, discussion points, and so on and so forth. And then follow that up with a 10 or 15 minute question and answer period, underscoring and outlining and re-emphasizing those points, questions, etc., within the case that we were trying to emphasize. Now, the case presentations will be by different clinicians. Dr. Neil Koo, who we'll introduce here in a sec, has been a fantastic champion. We're going to ride his kind of championship efforts in trying to move this whole process forward. We have other infectious disease practitioners, both pharmacists and physician ID practitioners. And we also are going to invite you out there in different sites to present. And we'll set that schedule up. Again, we don't want to go from the top down. Rather, we want to be participatory in a wide spectrum. We want everyone to kind of be engaging in here. So we'll gather some information and have different hospitals, different sites, and so on and so forth to present a case throughout the year and set that schedule up. And we have a form, put information on the form, and then we'll get that information that comes back to us. We'll get that and distribute that case and that information, that vignette, out to everyone else 3, 4, 5 days in advance. So everyone has a chance to look at that case. And then when we present it, we can have a lively, robust discussion about what to do, what not to do, learning points, questions, so that that rising tide elevates all boats, so to speak. Okay, so we want this to be multi-congregational. Everybody pitches in. Okay, the members of our group, Erica introduced herself. She's a great epidemiologist for the state, Montana Department of Health and Human Services. She's also the project director for the state for the CDC funding that's funding this program, this process. And I'm sure most of you are already familiar with her, with the work she's done over the last year with COVID. Welcome, Erica, and she'll serve as a great resource. We also have Dr. Jenner Minto. Dr. Minto is a professor at the University of Montana School of Pharmacy, and she's served a 2-year fellowship in antimicrobial stewardship and infectious disease here at the School of Pharmacy, and has worked over the last couple of years with Erica in the state and outreach. And so many of you are maybe familiar with Dr. Minto as well. And my name is, as I stated before, is Vince Colucci. I'm a professor at the School of Pharmacy here in Missoula. I've been here for about 23 years. I also have a practice site at the Providence St. Pat's and International Heart Institute. So I have some credentialing both in cardiology and infectious disease. So I'm leading things off here today. And then our featured speaker and champion of this project here is Dr. Neil Koo. Dr. Koo is an infectious disease physician, well-trained, well-credentialed in that. He's been highly involved in it, and he also is the epidemiologist for the Billings Clinic in Billings, and serves as one of their infectious disease physicians and as their chief epidemiologist. So that constitutes, the last slide I want to throw out here is, this is kind of our scheduling for the academic topics as we go. As you recall, I said that first 15 to 20 minute segment will be on a topic that we want to introduce, underscore, reiterate a principle to you all regards to antimicrobial stewardship. So hang on to this piece here, and this will kind of lead us off as we go into the monthly discussions and so on and so forth, and kind of relate that to our case, so we can get a core academic principle foundation, and then follow that with a case. All right, and then Erica and Jen, remind me, are we recording this? Yeah, so all the sessions will be recorded. So if you unfortunately miss one, that will be, I don't know where we're gonna store them.
We are hoping to work with Mountain Pacific Quality Health to store them on their website, but that hasn't been established yet. So this one will not be readily available. If you do want the recording, send me an email or email Erica, and we'll make sure we can get that link to you.
Okay. All righty. So with that, I'm going to turn this over to Dr. Neil Koo.
Thank you, Vince. So again, for those who are not familiar with me, my name is Neil Koo. I'm a infectious disease trained physician at the Billings Clinic. I serve as their hospital epidemiology, their medical director of the infection prevention and control, as well as their medical director for antibiotics, the antimicrobial stewardship program. I also serve on the committee and the Antimicrobial Stewardship Committee with the Society of Healthcare Epidemiology of America, or SHEA, and as well as a member of their Diagnostic Stewardship Task Force. So I have the connection with a national organization, and I am essentially their a representative for rural parts of the country to bring antibiotic stewardship to Montana and places like Montana to see what we could do to kind of to bring stewardship and to comply with some of the newly developed or requested antibiotic stewardship to all hospitals, including critical access hospitals. So let's see. So let me see. And I think I'm going to share a screen, but one of the things as we were developing this, and we talked about when Vince and Eric and Jenner and I kind of put together, was that we're kind of trying to come up with a format that will engage everyone, because this is a more of a unique setting, because many of the facilities, critical access hospitals don't have all the resources that big academic or big city hospitals have. So we're having to put together ideas, share our resources, brains, whatnot, so that we can kind of try to implement, try to set up, implement, and run your antimicrobial stewardship program. So we really hope that many of you will be more engaged. Certainly ask questions. It doesn't have to be, if your question it doesn't pertain to this the week's presentation, then you certainly can still ask, just so that we can can help you out, as well as anyone else who may be actually having the same question. So I would say that I would treat this discussion more like a town hall panel discussion, rather than just a specific discussion about the case that being presented that week. So with that said, let me see if I can make this work. I'm going to share my screen. And let's kind of start with to kind of start with our first case, and just and this is just going to be more of an appetizer to kind of get to get a sense of what we're trying to accomplish, and a little bit of the format. So I know that we had Vince has placed on the slide, the week one was really talking about some identifying metrics, but I want to kind of get but this is kind of pre week one, so to kind of get an idea what we're trying to get accomplished with these webinars. So with that being said, I'm going to start with our first case. So this is a patient that I actually saw a couple of weeks ago when I was on the inpatient ID consult service. So this is a 54-year-old man with Crohn's disease and chronic kidney disease who had underwent a cystoprostatectomy and ileoconduit formation in earlier this year on February 19th. Now, he was seen from an outside facility and actually sent to Billings Clinic for further evaluation. But he, when I was in a consult to see this patient, he was admitted overnight for a management of presumed nut pyelonephritis. His interview revealed that he indicated that he had been feeling pretty well up until the day prior to his presentation, when he started experiencing fevers, chills, and malaise. He was from out of town, and was seen at a local clinic where they did blood work and noted that he had leukocytosis. And because of the ileal conduit, this happens quite often. Any suspicions for infection, the urinary tract has always been suspected, so a urinalysis was performed, and it was reported as positive for a urinary tract infection. Now, he reported to the provider and as well as to me afterwards that he had no abdominal or flank pain. But because of the concern of this, possible sepsis, with the fevers and chills and leukocytosis, that he was, as well as this complicated, intra-abdominal anatomy, he was sent over to Billings, the ER at the Billings Clinic for further evaluation. So in the ED, he was noted to be febrile. He had a temperature of 102.4, and he was slightly tachycardic with a heart rate of 100, breathing slightly fast at rate of 22, and a blood pressure of 102/71. And he had a 95% oxygen saturation, and this is on room air. His physical exam was really notable for slight tachycardia on his cardiac exam, and that on his abdominal exam he had an ostomy that was present that drained his ileal conduit. And there's a bag that covers the ostomy that was connected to a draining tube that led into a collection bag. There were the bag, and I didn't indicate here, but the bag had contained yellow clear urine with some sediment on the bottom. There was on my exam he had no abdominal or flank pain with both palpation and percussion. Now, laboratory data had showed was notable for CBC showed a white blood cell count of a 16.9 thousand. So it certainly has leukocytosis. Other abnormal laboratory findings include BUN of 35 and creatinine at 2.87. I did not have any previous numbers to see of his creatinine to determine if this is a change or not, as he had a majority of his care outside of Billings Clinic. So, but I know that he has an underlying chronic kidney disease. So certainly this laboratory finding would reflect that. And then they had a glucose of 113. A urinalysis was performed, and it showed was notable for a protein of 30, moderate blood, and that it was large amount of leukocyte esterase. And on microscopic exam, there was about 713 white blood cells and 12 red blood cells and 4+ bacteria was noted. In abdominal imaging was performed by computed tomography, which showed mild increase in inflammatory stranding surrounding both kidneys. However, this was unchanged from a CT that was performed just a couple of months prior in May. The only that was notable finding that was different from May was that there's some increased stranding around the right renal pelvis. And therefore, the diagnosis of pyelonephritis was made actually based on the CT findings primarily. Cultures of the blood and urine were performed, and then he was admitted for fluids, as well as started on intravenous antibiotics, specifically vancomycin and ceftriaxone. As the provider had the ED provider had indications that he had MRSA grown out of his urine culture in the past. Now, the following day, he improved clinically, and this is around the time where I was consulted, and he had no further episodes of fevers and chills. Now, his urine culture was after a couple of days, isolated Klebsiella oxytoca, which was noted to be pan-sensitive, and he had, like the previous urine culture results, methicillin-resistant Staphylococcus aureus. Now, given his remarkable clinical improvement, he was then transitioned to sulfamethoxazole trimethoprim for oral therapy, and then was subsequently discharged home. So the question is did this patient have a urinary tract infection? And this is something that it doesn't seem very obvious, because most clinicians approach this, certainly based on a lot of the approach, diagnoses are based on either an abnormal urinalysis, or in this case, even so, is that there is an abnormal CT. However, there's also the assumption based on that diagnoses are made based on the response of antibody therapy. So that and this is kind of one of the things that we will kind of touch on in subsequent webinars we kind of discussed about, because the challenge is that as clinicians get more and more comfortable making diagnoses this way, many more antibiotics, this increases a lot of the incidence of inappropriate antibiotic therapy. So certainly the biggest concern from our side is, was this appropriately diagnosed? And it may, from a clinician standpoint, it may not be as a big of an issue. And certainly when you as an antibiotic steward going to try to intervene, that's going to be the biggest challenge, is because is that if they are convinced that that is the diagnosis, anything you're trying to intervene will become very difficult. And this but on the other hand, we as antibiotic stewards have to consider, if we're going to try to make sure that patients are treated appropriately, why should we? And this is and so some of the points I want to make about this. Why is inappropriately diagnosed UTI such a big issue? Well, certainly we know that, as I pointed out earlier, is that this increases antibiotic use, and we see this as an ID physician. We see this very commonly, especially little old ladies with asymptomatic bacteriuria and pyuria. They get diagnosed with a UTI, even though they have no clinical symptoms, and they get placed on multiple courses of antibiotics, and recurrently actually. And eventually, when they do develop a UTI, an ID consults are all commonly requested, because the bugs eventually develop something, which is what we usually get consulted about, is that they become resistant. And that's usually what happens, is that they get multiple courses of antibiotic therapy, and we see a lot more resistant bugs. Now, again, that's and interesting from my practice, I would say well over 50% of my consults of those patients with presumed UTIs is really to address the antimicrobial resistance, not the fact that whether or not this patient the patient I've been referred to actually need antibiotics. Other things this is probably the biggest fear, but we don't think about it. Is that are we treating the right infection? And this is a concern, as I pointed out, regarding that a good number of clinicians tend to use antibiotics as a presumed response to antibiotic therapy as a diagnostic tool. So in someone with, in our case, a UTI, certainly if someone may have something like a diverticulitis, for example, and they would probably respond to the ceftriaxone. But certainly the antibiotic regimen and the antibiotic duration are very different. And so we want to make sure that we're treating the actual infection. This is, as we all are familiar with, is that increased antibiotic use, and especially broad spectrum antibiotic use, increases the incidence of C. difficile infection. So in addition to increased antimicrobial resistance as a result of antibiotic use, we also see more C. difficile infections. And so, and again, so a lot of antibiotic stewardship is really tied, as one of the metrics is tied to the incident, how effective your stewardship program is tied to the incidence of C. difficile infection. And then finally, this is a big deal for all of us, particularly here in for larger institutions where we use devices quite often, but that if we inappropriately diagnose someone with a UTI, that this will reflect onto our reporting to NHSN. So this has been one of the things I do quite often, having to help address quite a bit as an epidemiologist and as well as medical director for infection prevention, is that we have to we certainly, in addition to making efforts to limit the number of counties or CLABSIs, but we also want to make sure that if we're going to get deemed, that we get deemed for the right cases, for right actual infection that caused, and not because it's a misinterpretation of laboratory results. Now, most of my discussion here is going to be more focused on diagnostics, and so a little bit, and certainly less to less on management of antibiotics and antibiotic stewardship. But keep in mind, antibiotic stewardship and diagnostic stewardship, even though they're two somewhat different thing, they have a lot of overlap, and they go hand in hand. So as I pointed out, is that earlier on the earlier slides, is that our discussion is really on how do we determine does this patient have a UTI? And one of the things that 99% of clinicians almost always use urine tests to make that diagnosis. And the two most common tests are the urinalysis and the urine culture. So the urinalysis is probably one of the most commonly ordered tests by clinicians. I mean, it's and partly is because it's very simple to perform. I mean, you get a patient to urinate in a cup, and most clinics will have their own little. They have dipsticks that they just dip into the urine samples, and they can get a result in a matter of a couple of minutes. So it's very, very commonly ordered. Now, it has a very, very wide variety of uses. You know, we commonly associate UAs, many clinicians associate UAs with ruling out urinary tract infections, but other specialties use UAs for other reasons. Particularly nephrologists will look at very different other factors, you know, whether to rule out to look at proteins, or whether there's going to be casts present in the cells, and they also go a little bit more specific in urine sodium, urine creatinine, things like that. So there is a very wide ranges of who uses and for who use a urinalysis, and they're all for very different reasons. But one of the things the point I want to make is that there is no standard criteria for using urinalysis to diagnose UTIs. We are commonly taught, either in med schools or even in nursing schools, even in pharmacy school, that abnormal urinalysis, that is having a presence of leukocyte esterase, having a presence of nitrites, have seen white blood cells in the urine, all and finally bacteria in the urine, all point to the diagnosis of UTI. But there is no true standard criteria, and that's I will explain a little bit of limitation in the next slide why that's the case. On the other hand, is that the other commonly used test is the urine cultures, and urine cultures are, especially in my line of work, I see this commonly used. A lot of are commonly used are performed either part of a pan culture panel. When someone is in a hospital and they develop a fever, that kind of it's not uncommon to hear a provider on call in the middle of the night to tell the nurse, okay, pan culture a patient. And usually urine is one of the specimens, body fluids, that gets collected for this. It's also gets performed, fortunately, as a result of a reflex. And this mini lab, because of the notion that abnormal UAs can be used as a diagnostic test to determine UTIs. To make things simple, a reflex, mini laboratory choose to do a reflex of a set of when the UA shows meets certain criteria, it will automatically reflex their cultures. However, from my standpoint, the most useful what makes the thing that's the most useful for urine cultures is that it helps direct antimicrobial therapy. And that's really what most of ID physicians are kind of look at it. We don't use urine cultures to make the diagnosis. We use the urine cultures to, after we already made the diagnosis of a patient with UTI, to ensure that whatever antimicrobial agents we have prescribed matches the organism that's isolated. And finally, this is what, as I pointed out earlier, is that urine cultures are a part of the NHSN diagnosis. One of the criteria for NHSN to diagnose CAUTIs, or catheter-associated UTIs. And so inappropriately ordered urine cultures can actually trigger and meet the case definitions for CAUTIs, even though the patient does not have a UTI clinically. And this is one of the reasons we have, why it's important to ensure that if urine cultures are performed, especially in someone with an indwelling urinary catheter, that they're performed for the right reason, because because it's NHSN doesn't look at it clinically. They look at it in the context of meeting a certain set of criteria. Now, as I pointed out, there are also from the previous slide, there are limitations to urine studies. So UAs are pretty sensitive in general, but not very specific in diagnosing UTIs. Or let me put it in another context. It is very good, it has a very good negative predictive value, but it has a horrible positive predictive value. So you can use a UA to rule somebody out for a UTI, but you cannot use it to make the actual diagnosis alone. And that's leading to the next point, is that these results have to be, any UA results have to be interpreted based on existing clinical factors. If a patient has no urinary symptoms, it does not, and the patient has an abnormal UA, it does not make the diagnosis. So, and in the case of someone with a urinary catheter, it's not uncommon that these patients will have pyuria and bacteriuria, that they have presence of white blood cells in your urine and bacteria. And therefore, because of that, they're not, regardless of symptoms or an infection. Therefore, that's why they're not useful in the diagnosis of CAUTIs. Urine cultures, on the other hand, it has as I point out, has very limited diagnostic utility, because until you know that the patient has actually clinically has a UTI, you cannot use a urine culture to make the diagnosis of UTI. One of the key things about the urine cultures is it's very, very susceptible to sample collection errors. So this is where having a clean cath is much preferable than in and out cath is better than a clean catch, because again, you certainly can pick up other bugs if the sample is not collected properly. And then finally, as I point out, why the reason that that urine cultures are not useful for diagnosis of UTI is because bacteriuria is actually normal in certain populations, specifically in the elderly and a good number of those who have indwelling urinary catheters. So now there's two articles I want to kind of just run out to kind of point some to reinforce some of the points I've made. This is a good one of the articles that was recently published in ASHE, or stands for Antimicrobial Stewardship and Hospital Epidemiology, and looking at the urinalysis. As I pointed out, this article had review what all these common notions of what UAs are being used for and why they're used, how it kind of led to this whole notion of why we almost always equate abnormal UAs with UTIs. But they also kind of talk about looking at ways that we can approach and using trying to change how clinicians perceive UAs, and to help and use that to help our goals with diagnostic and antibiotic stewardship. So one of the things that they kind of talked about is this, and this happens certainly everywhere, is that we have quite a hot number of unnecessary ordering urinalyses. If you look at our ER, it doesn't matter. You could have a toe twitching and a UA gets ordered. Again, as I point out, the reason for that is because UAs are very simple tests to perform, and clinicians, just like the CBC and this Kim 7 and whatnot, is that there is a kind of a knee-jerk reflex to order these labs, even though they're not pertinent to this, what the patient presentation is. So limiting the unnecessary ordering of urinalysis is going to be one of those big key things that we'll have that suggests to kind of trying to address. Now, how do you go about doing that? That could be a little bit of a challenge. I think that at least you could certainly look at different ways, like in an outpatient setting, where because many now all healthcare facilities, including clinics, are linked up to an electronic medical records, and many of them have embedded quote power plans or order sets that they have all these set of labs inside. And so going through these order sets to kind of eliminate UAs, and so automatic ordering of UAs could certainly help address some of this, trying to accomplish this goals. Now, certainly, if you don't want to just take out all the UAs, you also want to define appropriate uses of urinalyses, because certainly there are times that we'll need to use them. So the urologists will need them, the nephrologists and such. And so we trying to help work with those specialties and to kind of try to limit the use of urinalyses will help kind of achieve the goal of limiting the number of UAs being ordered. This is kind of a novel way of approaching this. Is one thing about UA, and this is something I've seen at every facility I've worked at, is that UAs are always reported the same way, regardless of the reason you're ordering for. Whether you're ordering it for a UTI versus you're looking at UA to look for cell counts or whatnot, or for whatever reason, they're all ordered the same way, and the results are all reported the same. So this will require this suggestion, which requires a little bit of work and coordinating with our laboratory as well as IT folks, is to create UAs and break it down into reasons for ordering it, and then have the results that's pertinent to that condition for the reason they're being ordered to be reported, rather than report everything that comes up on a UA. So, for example, if let's say we're looking for we're looking for proteinuria in someone who is a diabetic and needs to has part of their screening exam, then we just have a urine study that's specifically geared toward that in the computer, and when it's ordered and performed, the only results that comes out will be the urine proteins. So all the white cell counts, all the micro exam, things like that will not be excluded from the UA. So to try to narrow and direct these specific components to the reason that they're being ordered can also help kind of thwart and avoid this, these inappropriately diagnosed UTIs. And finally, any project, and this is going to be something we're going to talk about in the coming months, any projects you're going to create, you want to start small. You don't want to go and implement the whole facility, because it gets pretty hairy after when you're trying to get every piece work in place. It gets really very, very challenging. So, to avoid being discouraged by, or get the sense that whatever you're doing in interventions you're trying to do, you want to start small first and then expand. The other article I want to point out just really briefly is just talk about what our understanding, physicians and nurses' understanding about urine cultures. This article specifically targets urine cultures in catheterized patients. And again, remember we talked about counties, and that urine cultures is actually one of the criteria, abnormal growth in the urine culture, as one of the criteria for making a diagnosis of counties. So certainly we want to look at, this article looked at how doctors and nurses approach urine cultures and what we can do to intervene to address these inappropriately diagnosed counties. Well, now first is that they did a survey of these of both physicians as well as nurses on why they would request or order urine cultures. And it's interesting because they're two very different reasons. The nurses look at reasons for ordering or concerns about having a UTIs and asking their providers to order urine cultures is based on more physical findings. Cloudy urine, smelly urine, urine sediments, maybe abnormal laboratory findings like leukocytosis. And nurses tend to have this notion that you want to have a follow-up negative urine culture to ensure that if someone gets treated, that they're successfully treated. Physicians, on the other hand, has a very different approach. A good reason, many reasons for ordering cultures is this pre-procedural testing. Just like a lot of these, it comes into part of the these screening and automatic ordering part of a panel. Many surgeons and proceduralists like to order UAs, although there's no really good data to show that that actually has any added benefits. So that's one of the big reasons where physicians or UAs get, or urine cultures are performed, is because it's just part of a order panel. But physicians also look at other more physical finding, other symptoms like dysuria and pyuria. And then ultimately, and as I pointed out, urine cultures are always ordered as part of a pan culture map. When a nurse calls and asks, hey, Mr. Jones has a temp of 102, the good response, typical response is pan culture the patient. So, and that's one of the reasons that urine cultures get ordered. Now, how do we address these issues? We can look at, there are two, this article suggested two approaches. First is a human factors engineering, and to look at what we can do in different aspects to kind of help eliminate the inappropriate urine cultures. Now, one of the big things, and this is something we do here in Billings Clinic quite often, is that if someone doesn't need a catheter, we try and we determine and we assess them on a daily basis to see if they still need a catheter. Certain indications to find out if the patient still has the indication for the placement of the catheter. And that should be done on a daily basis. If they don't need a catheter, it should come out. And then certainly the hope is that will eliminate this inappropriate ordering urine cultures, because you're not culturing, if there's no catheters, then you don't have to worry about concerns about cavity. Certainly, you want to make it easy for catheters to be removed. Having stop orders is very important, and that's something we're working on at Billings Clinic. And this would certainly, we instead of having a nurse or someone just consciously decide, as part of the assessment, you could set up a set of criteria that will lead to automatic discontinuation of catheters. We definitely want to change ordering behaviors, and that's kind of in two forms: and placement of catheters as well as ordering urine cultures, because you don't want that immediate reflex, just like the pan culture, to order a urine. But that is, and that can be a little bit challenging. I'll kind of talk about that in the next slide. But that is going to be the ultimate goal: is trying to get the clinicians and the nurses to think that the urine culture need to be ordered. And then finally, you don't want this urine culture to be automatically ordered just for no reason at all. So certainly going through our order sets and order bundles so that they don't automatically get performed. Now, how do we get, but the second component that this article suggested is engagement with the nursing staff. And this is going to be very critical. So we want, is that, as I pointed out, there's a lot of misconceptions that's already built into our knowledge. We're taught, medical school, as well as PA schools, nursing schools, that we're taught a very way about our how we see and understand about urinary tract infections, including cavities. We want to, certainly nursing staff had to be, I think, re-education of how the nurse is going to assess a patient, that they don't need a knee-jerk reflex of ordering a urine studies because there's a cloudy urine or smelly urine or whatnot. We definitely want to also, and this is very important, is how the nurses present to their providers, because that interface significantly influence what the provider will say. If a panic voice of a nurse panicking on the phone saying, I have a patient who's this, it will automatically incite a pan culturing order. But on the other hand, is that having the nurses being very, how they're going to address the issues by first, I'm going to notify the provider, and then I will let you know if this persists. That may kind of curb some of that that knee-jerk reflex that usually made by providers. Having nurse-driven protocols for catheter maintenance is, I think every facility should have this, but not everyone does it. So this is, requires coordination of the antibiotic stewardship team with the nursing staff to make sure that they're doing the proper period care and such, so that yes, that for patients who do have to have catheters, that they're maintained as best as it can, and that they're exchanged as frequently as appropriate, so that minimize the risk of cavities. And then finally, again, if they're going to be a cavity, and if we're going to be diagnosing this correctly, want to make sure that the nurses are collecting the urine samples appropriately, and that they're and that they're not going to be collected through a bag or a tube, which I still hear that quite often. And again, this is kind of follow up with some, if we're not able to completely eliminate inappropriate use of urine cultures as a diagnosis, at least make sure that we're collecting the samples appropriately, because when you get abnormal findings, that's what incites a lot of inappropriate antibiotic use. And that's all I have. So this kind of leads to that last portion of our webinar. So any questions, concerns, or thoughts? I'm all ears. So.
Thank you, Dr. Koo. We do have a question in the chat box. So how do we address the issue in skilled nursing facilities related to testing urine due to new altered mental status? We haven't been able to address this issue successfully, as the providers feel that it is a clinical symptom of UTI.
So do you want me to give that a shot, Vince? I don't want to talk this out.
Actually, I'm going to punt that over to Jenner. Jenner, what did you come up with when in some of the in your DUE and some of the work that you had done with UTIs in skilled nursing facilities?
Yeah, so that is one that at our local skilled nursing facilities here in Missoula, the medical director felt very strongly that altered mental status should not be a reason for ordering a urine culture. And so she was very adamant that that not happen unless there were other urinary symptoms. So it was actually fairly easy for us to address, but I will say that it would not have been easy to address if she hadn't felt so strongly about that.
I would add, having worked in a nursing home in a skilled nursing facility before, the challenge is that the clinician is, well, most clinicians are, I was fortunate, I was still an ID doc at that time. So I understood all the why it wouldn't be a knee-jerk reflex of ordering, assuming that UTI is a cause of altered mental status. But for most clinicians who go to care for patients in a skilled nursing facility or assisted living or a nursing home, they're looking for a very simple, straightforward solution. And if there's no alternative diagnosis readily available, that's usually what they fall to, is this must be a UTI. Now, it doesn't help when they check a urea, and as I pointed out, pyuria and bacteriuria is very common in elderly population, whether or not they have a UTI or not. And so that tends to reinforce their notion of that, oh, this patient has a UTI. Now, how do we address that? That's is a very good challenge because it really will require a effort both on the leadership, the medical director at the skilled nursing facility, as well as their nursing staff. Because remember, what triggers a lot of what a clinician does is what the nurse tells them. And if the nurse tells them something, and they tell them that we don't think of it this way, but whatever nurses say guide the clinician much more than what we really willing to admit. So, and this is what, so definitely training the nurses, setting up a set of a protocol to kind of help guide the nurses how they're going to report these data, and then and how do we address patients with ultramental status. And now I can already think of off on the top of my head some of the issues. Two most common causes of ultramental status in a skilled nursing facility or a nursing home are: one, recent change in medications. I mean, that's just common. And it's so surprising, but we ignore the fact that majority of these patients in nursing homes and skilled nursing facility are on either opiates or psychotropic drugs. They're on Remeron, they're on, I mean, some already on Haldol, I mean, some on Risperidone. And then you're adding all these other opiates, like even like oxycodone, if they're coming in for a hip replacement, so you have that. So medications, recent adjustment changes or addition of medications plays a big role. The second component is dehydration. And again, that is more common than even changing the medications. Most elderly population are much more prone to dehydration. And when you change their medications and they don't drink as much, it just it actually it feeds back and actually worsen the issue. So now, how do you address this issue is the biggest one, because what you're trying to do now is to try to nudge that clinician into doing something different than what they're very comfortable about. And let me point out that what's going to be the toughest part is that most clinicians are not consciously thinking what they're doing is wrong. Or better yet, or in other words, is that they're looking, what they're doing is more that this is they're looking at in the context of, well, that this is, I'm not trying to do something harmful to my patient. What I'm trying to do is this is what my understanding of what's wrong. So their intents are always never bad. There's no malicious intent, but our challenge as antibiotic stewards is try to nudge them from another direction to kind of like, look, I understand this requires some dialogue with those clinicians and try and say, look, I think a lot of these are not truly due to UTIs. Can we try this first before you call it? So you can't dismiss them, but also offer some solutions. So maybe hydrate them gently. That's a very option. And that can be done at any SNFs. Can you just give them about 250 milliliters of normal saline? Just give a small bolus of fluids, see if that perks them up. If that doesn't do it, then you can kind of let them do, go down the path. So that's, this is a very big problem. And this is probably a webinar in itself. What do you do with skilled nursing facility? So that's, but my point being is that don't make strict, I think this will require some collaboration, multidisciplinary approach to address these issues. If you can establish that, a lot of your other issues that occurs in skilled nursing facility, you can fix it because they all are essentially variation of the same issue.
Wonderful. Thank you, Dr. Koo. The next question that we have is, how do you work with providers who won't discontinue a Foley catheter when the nurse feels it is inappropriate?
I guess that's to me again. Huh? So there's a couple of ways to approach this. Again, it will also require a multidisciplinary approach. Just like trying to convince a provider not to order order UAs off the bat and start someone on antibiotics. You want to kind of collaborate and actually work on with them about why is this important? What are you trying to accomplish? Now, you will certainly, it depends on, and you'll have to finesse this a little bit. You could either, some places just makes it a hard stop. This is the rule. This is our policy. You do it. If you don't do it, you're not you're out of here. That probably not the best approach, but I've seen some places have done that. The other is that, you know, it's showing the data and whether and use that to kind of either give a nudge in the context of how well they're doing or what kind of problems they're running into. Again, many of these providers are doing this and more in the context of that I'm feeling like I'm doing this for the best of my patients. So you have to convince them why this is not the right thing. And that sometimes that does require showing the data about, well, you know, we're having a lot of problems with cavities, and that's because we're using these, you know, leaving these catheters for an extended period of time. So showing the data definitely is a way to kind of objectively determine that, hey, what you're doing may not be the best thing. We're not saying you're doing you're a terrible doctor, which just looks like things, you know, may not be the best practice. So.
Yeah, I would chime in on that. I think demonstrating individual data or data that you've accumulated at your site convinces if it's great that it's a study someplace else, but one of the responses I've always heard, yeah, well, that's over there. That doesn't occur here at our site, or we don't have those. So getting data from one's own site, I think is helpful. And then as a steward, as an antibiotic steward, sitting down and dialoguing and say, can we, you know, get them to come to the conclusion that we do have an issue here, and can we push it forward in a way that is beneficial, kind of create a win-win situation for everyone. And so rather than just kind of a hard stop type of a deal, I've always had more success in showing the data, sitting down and dialoguing, getting them to admit, yeah, okay, so that we had an issue. What do we need to do about it? So they become part of the solution instead of you're looking at them as the problem.
Any other comments on that question? All right, we do have another question. For patients who are prone to UTIs with indwelling catheters, is there an irrigation or flushing protocol that is shown to decrease the incidence of UTIs in this population?
Ooh.
Neil, I'm gonna let you handle that one. I'm not aware of any flushing protocol other than just, you know, reasonable hydration.
So the technology of these advances in preventing cavities while trying to maintain an indwelling catheter has not really advanced in the last couple of decades. You know, we have looked at practices involving flushing. We put antibiotics in there, even to oral, you know, or systemic antibiotic therapy. We have looked at silver impregnated urinary catheters. There's silicone versus rubber versus, I mean, we have looked at different permutations. None have really significantly made a big impact. And it's because of that, it's really kind of the primary focus on the primary strategy to reduce cavity is try to eliminate, ensure that try to decrease the use of them. And so, in other words, you only place a catheter if necessary, and to try to exchange them out on a regular basis. I mentioned about systemic antibiotics is a very, very popular thing, and I personally don't think it's a great idea. It's a short-term fix for a long-term problem that will ultimately fail. Again, it's another one of those common requests I get once, when I see patients in the clinic. There is also methenamine is very commonly used. It's not an antibiotic, but it kind of acidifies the urine and such. I mean, that's it doesn't affect antimicrobial resistant rate, but you know, it's worth trying if you want. But I would say if there's anything, that would be a case. But truth of the matter is make sure and placing catheter only when needed and exchanging it on a regular basis are probably the biggest is going to be the best strategy you have for someone with indwelling catheters.
The other thing I would add is ensuring that good hygiene is used, and potentially optimizing other comorbidities such as diabetes can sometimes be risk reducing in that setting, but it's an ongoing issue, that's for sure. Erica, do we have anything else, or are we out of time?
Yep, we just had a couple of comments. An individual who shared that they used to work in a long-term care facility and they did see, you know, antibiotics, the symptoms would improve after a round of antibiotics. So it's hard to sometimes convince that a UA should not be ordered. And it could have been just, you know, one of those timing things. But that are, you know, those are all the comments and questions that we have in the chat box right now.
Well, Dr. Koo, that was an excellent presentation, and thanks for kicking this off for us. That was great. We will get those slides out to everyone so everyone has access to the slides. Certainly, if there are follow-up questions, let us know, and we'll go forward next month with one, get the information out to everyone in a timely fashion so that we can all see you again, and hopefully this ends up being a very good and productive and engaging type of an environment and format for all of us to kind of learn. We'll be taking feedback along the way and progressing it, so that is an optimal type of a webinar. Comments, Dr. Minto, Dr. Koo, Erica?
I'd just like to say thank you to everybody who attended today. This is some really exciting attendance. We have more than 30 people on.
Okay.
Thanks
For joining, everybody. We're done.
Keep an eye out for an email from me with our next AMS date, time, all the call information. So just keep an eye out. Thanks all.